a 52-year-old female with rheumatoid arthritis presence with chronic neck pain and occipital headache. I am showing you lateral radiographs in flexion and extension and a sagittal post-contrast T1-weighted magnetic resonance imaging. Please describe the findings.
The flexion radiograph demonstrates widening of the anterior prudental space to 5 millimeters, which corrects on the extension view, indicating atlantoaxial instability. The sagittal post-contrast magnetic resonance imaging reveals enhancing soft tissue surrounding the dens, consistent with inflammatory pannus, causing moderate cervical cord compression.
What is your primary diagnosis?
The findings are diagnostic of cervical spine involvement in rheumatoid arthritis, with atlantoaxial instability and associated subdens pannus.
What is the threshold for abnormal anterior prudental space in adults and children?
In adults, an interval greater than 3 millimeters is abnormal. In children, the threshold is greater than 4 millimeters.
What is the posterior atlantodental interval, or PADI, and what is its clinical significance?
The PADI is the distance between the posterior aspect of the odontoid process and the anterior aspect of the posterior arch of the atlas. A PADI of less than 14 millimeters is highly predictive of neurological deficits and indicates a need for surgical stabilization.
Why is atlantoaxial instability a critical concern prior to surgery under general anesthesia?
During neck extension for endotracheal intubation, the unstable dens can slip posteriorly, compressing the spinal cord and potentially causing catastrophic quadriplegia or respiratory arrest.
What other cervical spine manifestations are seen in rheumatoid arthritis?
Other manifestations include erosion of the odontoid process, cranial settling or basilar invagination, and apophyseal joint fusion.
What are the primary differentials for an enhancing soft tissue mass around the dens?
The main differentials are calcium pyrophosphate dihydrate crystal deposition disease, gouty tophi, and amyloid arthropathy.
Finally, what are your clinical management recommendations?
I recommend urgent referral to a neurosurgeon or spine specialist to evaluate for surgical stabilization. The patient must be advised to avoid neck flexion and extension, and a soft cervical collar may be recommended for temporary support.